happening. We're going to get started. I have to be formally introduced by somebody else. So Stephanie is our wonderful person who's sort of in charge of all administrative things to do with RuDASA. She's actually going to be doing the introduction. I'll just bring up the slide for that. Thanks, Steph. So I'll hand over to you just to get us introduced, and then we'll start.
Okay, so let me just introduce Madeleine firstly as our mentor rep at RuDASA, and just to say that she has been a force to be reckoned with. This is the third event that she's run to do with helping people to adjust to working in rural health services. But officially, she's a family physician, and she works at East London and at CMH, which I can't remember what that is. I think it's the one hospital that she works at. And she's also just started as a senior lecturer at Walter Sisulu University. On the executive committee, as I said, she carries a mentoring portfolio, and she's the convener of the Diploma for HIV Medicine for the College of Family Physicians. So after qualifying at the University of Pretoria in 1995, she completed her family medicine specialisation in the UK in 2004 and did her diploma in HIV management in 2013. In 2009, she was awarded a Certificate of Special Merit from RuDASA for her work in mentoring in the Eastern Cape. And she lives in CMSA in the Eastern Cape with her husband and 2 children. And if you haven't been, that's a lovely part of the world. And she has offered a retreat there in the past for learning how to thrive in rural health. Okay, so over to Madeleine.
Thank you very much, Steph. Steph's the glue that holds RuDASA together. And yes, I must say the CMSA events was very lovely. We did it at Buccaneers on the beach just down here at the CMSA beach side, and a bit more pleasant than Zoom, but was much more difficult. We would never have gotten 30, 40, 50 people in a single meeting. And already on our training, we have over 150 people have already registered just for this rural onboarding program countrywide, and there's still more people getting on. So we are very excited about this training, and it's very much a course that's been created by people across the country who are just passionate about helping doctors getting started. So what's amazing about this, it's not funded by any NGOs or external organizations. It's all created by passionate, voluntary clinicians, which is why we're able to offer it for free. And RuDASA is just helping with sponsoring the administrative costs of doing a course like this, which has, of course, been made much easier by Zoom and having that as an access. So let us get started with tonight's presentation, which is about the ill immune compromised patient with HIV. Why are we doing this today? And I must just acknowledge that this presentation is already actually quite a few years old. In 2016, we were running a course for the Diploma of HIV Management in the Eastern Cape in conjunction with WITS RHI. I was working for Beyond Zero at that time. And this is one of the modules that we created for doctors preparing for the diploma in HIV management. And I worked with Dr. Woods and Dr. Moorhouse. The 3 of us sort of carved this out. And it was interesting when I looked at the slides, actually not much has changed in the world of managing the HIV patient before you get to ARVs. Once you get to ARVs, everything's different. But before you get to ARVs, everything's pretty much the same. And in a district hospital setting, the district hospital is really the heart of the primary healthcare cluster. If you're in a district, if you're in your little unit or your little area where you live, whether you're in the clinic or the CHE or the hospital is the beating sort of where all the patients flow through eventually. And it's therefore also the first point of contact for the very severely ill patient living in a rural area. The challenge is that often our patients are either referred very late from the clinic or they just present very late with advanced disease. And when we first made this presentation, these were usually people who weren't getting tested for HIV. But now the predominant amount of people you will see have already been tested for HIV at some time in the past, and most of them has been exposed already to ARVs sometime in the past. So in this workshop, we're going to focus on that patient that arrives in your OPD or in your casualty or in your ward who's ill and immunocompromised, our classic, what we call AIDS patient. And we're going to look at how we can, what's a good structured approach to actually manage a patient like that. So we, of course, have to have our own little story. This is Mr. J, who sort of represents many of the patients that we see. He's 27 years old, gets brought in by the family. Quite often they were actually sick for a long time, and then they get too sick to actually protest coming to the hospital. So the family loads them into the back of the car. He weighs 48 kilograms. He gets rolled in on a wheelchair into your casualty or your OPD. And the complaint is that he's been weak. He's struggling to walk. He's got a dry cough. There's no night sweats really, but there is some fevers maybe. And he's very apathetic in the consultation. His wife that's brought him in, or his girlfriend or the auntie, she does all the talking, and he does not contribute much to the conversation. Comes out that he's also got intermittent, very watery diarrhea. He's got loss of appetite. And when you ask a little bit further, yes, he did take Arvs when he lived in Cape Town in 2018 and 2019. Can't remember which one, but it was the one tablet a day. And then COVID happened and he came back to the Eastern Cape and it all went pear-shaped. And you look and you find at least there's a CD4 count on the system of 4 or so months ago of 42. So we know we're in the very low brackets. So this is a common presentation where we have a sick patient to come in, and quite often the main complaint is just they've been losing weight, they're weak, they might be pale, maybe they've got fever, maybe not, it comes and goes, maybe they've got night sweat, drenching, maybe not, there's always fatigue, there may or may not be some chronic diarrhea, there may be some mild confusion or headaches or this apathy that we often see in the very ill patient. And there's very few of any real localizing symptoms. So there's nothing you can really put your finger on, but the patient looks very sick. And probably the most consistent finding in all of these patients is loss of weight. So they're all getting thinner, they're all getting sicker, but it's not clear what exactly the cause is. So the challenge with a patient like that, and the reason why we're presenting it, is that because of the very low CD4 count, the patient is not making any inflammation. So whatever opportunistic infections they're busy getting, their bodies are not fighting those opportunistic infections. Just suddenly want to make sure I'm recording. Yes, paranoia. So our patient is, because it's not making inflammation, it's not making symptoms you can find. And because it's not making inflammation, suddenly all our normal diagnostic tests don't work as nicely as they should. So the classic thing in TB is they're not making nice cavities, so they're not actually coughing up any bacilli, so your gene expert can be negative, even though there's TB bacilli throughout the lungs. The other challenge is they're likely to have more than one significant diagnosis. So in HIV negative patients, you normally assume if the patient is sick, there's usually one thing going on. You're very unlucky to get two major unrelated diseases at the same time. But with AIDS, the exact opposite is true. It's likely that there's not only one big thing going on, there's probably more than one big thing going on. And the biggest challenge is there's a high risk of death. So quite often the patients come to us just before they're actually going to deteriorate and die. So and you can't always tell which one, they come in, they're really sick, you admit them to the ward, and the next morning they've passed away. And so one always has a feeling there's not much time to figure out what's going on and to actually manage the right disease quickly enough. I remember many years ago when we were still in the AIDS era, they actually did a study in Johannesburg where they did autopsies on a whole lot of patients who had died from AIDS. And each one of them had one diagnosis on the death certificate, be it they died of Kaposi or they died of TB. And then on the autopsies, they found that most of them had at least 2 or 3 major prognostically poor illnesses all happening at the same time. So important when we see our patients is to have a little bit of a mental diagnostic map in the back of our minds when we approach them, because we have 2 extremes. The one extreme is that we investigate for everything and just deplete all our resources on one patient in our general worry of all the possible things it can be. And on the other extreme, we start investigating, we find the one thing and we go, oh, look, it's TB. And we stop looking for anything else. So we need to find a structured way on how we approach these patients. Some things are easy to find, so we normally just look for them first. And of course, the easiest is if they've got sputum positive gene expert TB, excellent, easy. Hepatitis A and B, easy to test for, easy to find. A patient who's got seizures or has got focalizing neurological signs, you've got to get them to a CT scan. Space occupying lesion is relatively obviously easy to see on a CT. And then typical localizing bacterial infections. So they might have a nice classic massive pneumonia on an X-ray. You might have a nice obvious skin infection, impetigo, or very badly infected seborrheic dermatitis. You might have obvious Kaposi sarcoma. If you look at the ankles, there might be a big lymphoma. So some things jump out at you, and there's a relatively easy way to diagnose it and confirm it. But as your CD4 count drops, it starts getting more and more complicated. Once the CD4 count is under 200, you have to start thinking a little bit wider. So our next challenge now is our patients who's got TB, but they got sputum negative gene expert TB, so possibly extrapulmonary TB, and these TBs are not so easy to find, and we're going to talk a lot about this tonight. They might also have a bacterial infection, but it's got an atypical presentation. So the pneumonia doesn't look like a classic pneumonia when you look at the X-ray. It's not the normal organism. So you start treatment, but they're not responding to your standard treatment for pneumonia. Their skin infections might not look like the normal skin infections, and you can't tell if it's fungal or bacterial or what's going on. They might have severe chronic diarrheas that are not the usual organisms that we see in our HIV negative patients. And you can have bacteremias, for example, salmonella, or a range of different organisms we don't normally think of. And then you also just get some lovely, interesting fungal infections that we don't normally see. So we've all become familiar with Cryptococcus through the HIV world. Pneumocystis jirovecii pneumonia, we still call it PCP from the old days. Cryptosporidiosis and issosporiasis, we're going to speak about both of those a little bit later on. And you have to start thinking about these as that CD4 count starts dropping. And now when the CD4 is under 75, now you're in the world of weird and wonderful. And in a rural district hospital, these things become really difficult to diagnose. You might pick up a Pseudomonas pneumonia on an MCNS, resistant to all kinds of interesting things. And there's some atypical fungal infections that can be really hard to diagnose and can cause disseminated pictures or skin pictures like histoplasmosis. You start seeing your CMV. CMV can give a classic CMV retinitis. It can also affect the colon, and you can get a very bad diarrhea, difficult to diagnose in those cases. But CMV can also give you a pneumonia. There's Mycobacterium avium colitis complex, also typically gut symptoms, pancytopenias, not so easy to diagnose. AFVs might come back positive, but it takes a while for the culture to give you a result. You might start finding your lymphomas in your central nervous system. And things like parvovirus infection of the bone marrow, and there are many more. It's just to give you an idea that the lowest CD4 count is, although you're going to start looking for your typical organisms first, you have to have a very high index of suspicion to refer if your patient is not responding to treatment. Because there's some things you can't find when you're in a district hospital setting because you don't have the resources and the capacity to do so. So in the old days, I don't know, we don't do this anymore. We used to always have a poster on the wall with all the different conditions you consider depending on the CD4 count. You should put those back, really. And the world of ARVs, in theory, should have changed this. In theory, we should be testing all our HIV positive patients, and they should never get to this point. And a useful thing to actually have is the good old-fashioned WHO staging, which shows you roughly on the different stages of diseases, what kind of conditions do you want to start thinking about. But let's get a little bit more practical. Oh, and just also, your patients also might have other things that can cause them to lose weight that might not be into your typical HIV things only. So also don't forget cervical cancer. Make sure your patient's been having their pap smears done. We had an elderly lady like this once who had severe loss of weight with a nice suppressed viral load, and CD4 was going down. We were investigating her from top to bottom. And meanwhile, she had a nice quiet cervical cancer that had not been picked up. Watch out for disseminated Kaposi sarcoma. 15% may have no skin lesions, but they might have Kaposi in the lung or even in the gut. But patients with HIV are also more vulnerable to develop cancer and to develop cancer earlier on. So your normal breast, colon, lung, and your other cancers. And then lymphoma, particularly common in our HIV patients. So non-Hodgkin's lymphoma, much, much more likely in HIV patients than the rest of our population. And the B symptoms related to the lymphoma can often be confused as TB. So quite often we might get on the TB bandwagon and we might miss something else. I once had a patient who came into Ngobela Hospital, where I used to work, a TB hospital, and he had a massive pleural effusion, and it had grown, lots of lovely TB. So he was started on TB treatment, not responding at all, which is why he was admitted. And then as we investigated further, we sent some cytology, and in the end, we had to CT scan him. He actually had a mesothelioma, and the TB was actually now secondary, partly triggered by the fact that he has a mesothelioma, and we were only focusing on the TB. So to start our diagnostic journey, I'm going to give you a little roadmap on how we're going to go about it. And starting in the beginning, as soon as your patient comes in with HIV, you got to know where you are on the journey. So obviously, anybody that you don't know their status, do an HIV test. Anybody who's HIV positive, this is the time to do your CD4 count. We don't like doing CD4 counts once we're on ARVs, really, because if they're on ARVs and the viral load is suppressed, the CD4 is not particularly helpful. But once the patient is not, if the patient's not on ARVs, or if the patient is sick, CD4 count gives you a clue on the things you need to consider. And if your patient's on ARVs, you have to have a CD4 count as well as a viral load to tell you where are we at with ARV management in this patient. So when we approach the patient, we actually start with the systems that is more likely to kill him quickly, if I could put it that way, or more commonly to be seen. So we usually start with the pulmonary system because TB is our huge, big concern. We're going to first look for TB or extrapulmonary TB and our lower respiratory tract infections. Then we're going to move on to our neurological conditions because those are potentially dangerous, look at our abdominal conditions, and then at our other systems. So this is the approach I'm going to work through tonight. So when we look at our patient, so we've got our gentleman with his cough at the moment. He's got some loss of weight. He's got some respiratory symptoms. So the first thing you always do is your gene expert for TB. Our challenge is, as I've mentioned early, as we're going to assume a lot of these patients with a low CD4 count, the gene experts often come back negative. To be able to cough up bacilli, you've got to make holes. If you don't make holes, the bacilli just happily multiply within the alveoli and you can't cough them up. So one of your tricks is to do your x-ray next, and please don't use your x-ray first. Do your gene expert. If your gene expert's positive, you might not need the x-ray. If your gene expert's negative, now's the place for the x-ray. And very important to remember asking for the laterals. We'll look at some pictures in a moment to try and look for that lymphadenopathy. If the cough's very productive and they're coughing up loads of junk, it's very useful to also spend your sputum MCNS. So often you will have dual diagnosis. So you might not only have TB, you might have a pneumonia on top of your TB. The lower the CD4 counts or the poorer they respond to treatment, you want to keep in the back of your mind Staph aureus, complicating it, Pseudomonas, and then some of your real weird and wonderful when the CD4 counts are very low, like CMV, herpes, etc., of the actual lungs. Just a couple of tips on pneumocystis jirovecii pneumonia. Any patient who's got a low CD4 count under 250, and it's not been on any Bactrim, you want to start thinking about maybe this could be PCP. And of course, in our current setting, you also want to consider COVID-19. Remember, any patient who's got lung damage from TB or might have a bad TB condition, even if the CD4 is higher, can also have a pneumocystis. So don't discard it just because the CD4 count is a bit higher. And the classic picture with these patients are they've got quite severe short of breath. They've got SATs under 92%. But when you listen to the lungs, it actually doesn't sound that bad. And when you do the x-ray, it's not nearly as bad as what the patient looks like. So you might have a non-specific pattern or a mild reticular nodular pattern, and the diagnosis is made clinically. So this is something you have to suspect. And as soon as you suspect it, you've got to start your high-dose Bactrim. We're not going to be able to send away fancy testing to be able to confirm pneumocystis in a district hospital setting. And the challenge is your patient might have TB and a PJP on top of that. So it's not uncommon that at the beginning, you might look at your patient and do your COVID PCR by all means. And if that's negative, you might end up saying, well, it looks like TB and PJP, and you might actually start treatment for both. So there's my remembering PCP. And then, of course, on the x-ray as well, you might see a pleural effusion or ascites. Obviously, do your TAP and send for your MCNSs, look for protein, LDH, your ADA. Always do a gene expert and always do a TB culture. You always want that TB culture in the back pocket when you can have it, just in case you're dealing with an MDR. So whenever you get fluid, don't just send for gene expert, make sure you've got a culture in there. And then in your HIV positive patient with a pleural effusion, even before you get your TAP back, you're going to start your TB treatment. And even if it's not an exudate, you're also going to assume that it's probably TB. So in your HIV positive patient with a very low CD4 count who's not making inflammation, might even have a transudate because of TB. So let's go back to Mr. J. Great. So we look at Mr. J. So we're seeing him today. Remember, he's our 27-year-old, CD4 count of 42, loss of weight, chronically ill. And you've got the gene expert result, which the clinic has very happily done for you before they sent him off to the hospital. And the gene expert is negative, no big surprise there. And you do your x-ray on the spot at your hospital because you can. And there's some very non-specific mild hilar lymphadenopathy. So now we're going to do a little poll. And the question is, on this picture, where you are at the moment in your district hospital, would you start on TB treatment today, yes or no? And I'm going to putting up a poll, and I'm going to give you a minute to just tell me what you think you will do with this particular patient. So those of you that are live streaming or watching the recorded version, my question here is a 27-year-old with loss of weight, dry cough, gene expert negative, and hilar lymphadenopathy on X-ray. Would you start him on TB treatment today? And we're having already lots of people, 15, 16, 17 has. Lots of people are busy giving input. I'm going to give it another 10 seconds or so. So please give us your answer. And yes, thank you very much. So we've got 82% of people have participated. Just for the record, later on, the more you need to do at least one poll on the call if you want to get a CPD certificate, if you are eligible for CPD points, just so we can make sure you were actually present and listening. So out of our poll at the moment, we have 71%. I'm hoping, can you see that? Yeah, I don't know if you can see that. 71% has said that, yes, they will start TB treatment today, and 29% have said, no, they will not start TB treatment today. Great. And these things are not so straightforward because it depends a little bit on the resources that you have. It depends a little bit on what you look at with the patient. But what we're going to do, I'm just going to give you the answer, or I'm going to tell you what we did with this patient in a minute, but just to give you a bit of just have a couple of slides on possible x-rays of lymphadenopathy. So there we have some, it's nice if it's that classic. It's not always that classic. It's sometimes quite non-specific. And there's the lateral. So this is the important thing when you're looking for TB. And if you've got a nice classic lymphadenopathy like that, yes, you'll be much more tempted to start your empiric TB treatment. And you can see, this is what we call the donut sign, because you can see your lymph glands are surrounding that bronchi coming out of that trachea or out of that bronchus, main bronchus, nice and beautifully. So in this case, we decided to not yet start him on treatment. The patient had just arrived in the hospital. We started him on Bactrim, and we thought we'll do a few more investigations to try and figure out where this TB is. We did not have any other confirmation yet of TB. So if you want to try and put some more things in the pot in your hospital, okay? And of course, at this stage, you'll have to decide about admission. Does he have any danger signs? We'll talk about that in a minute. That might make you put him in hospital, but we are going to do some further investigations. So now I'd like to do, and this you're going to put in the chat for us, okay? I want you to put in the chat any investigations. You can just pick one or two, doesn't matter. We're going to put a whole list together. What other investigations are you now going to do on this patient because you, in this particular scenario, with everything we know about him? So what investigations would you order? And you can put them in the chat there for us. Okay, great. Yes, I've already got a full blood count. We've got a ESR, yay, we've got a urinary lamb, excellent. We've got a cusp, great. We've got a full blood count and diff, liver enzymes, and urine lamb. Another ESR, excellent. Anything else anybody would like to do? So somebody's added in, yep, normal full blood count, UNE, CMP, ESR, HIP studies, urinary lamb, excellent. Protein and albumin, yep, one can look at that as well. We'll look at a moment how we sift through all the different possibilities. Great. Okay, so let's move on and see what we're actually going to be doing. So what we want to do is we want to think a little bit systematically, because your challenge is you don't want to deplete your whole NHLS budget on one patient. So you want to be quite strategic about what am I going to do in this particular patient that is actually going to be helpful. And we've already got our x-rays, so maybe we would have also picked up some ascites on there, some pleural effusion or pericardial effusion. We've looked for a lymphadenopathy. And then the next big test, which you can do on the day, is obviously that urinary TB LAM. So we go through different phases with the urinary TB LAM, where we have or we don't have. In theory, all district hospitals should have easy access to TB LAM. And I want to show you a couple of slides out of the new guide on TB LAMs, because they've widened the scope of when you might do a TB LAM. So this is out of a policy update brought out by the Department of Health. It's called the Guidance on the Use of TB LAM, and very helpfully it has what the old guidance used to say, what the WHO recommends, and what the new guidance is for when we can do TB LAMs. And the first slide I'm showing here is for the inpatient setting. So this is showing that we can actually be a little bit more generous in who we do TB LAMs on, if you have loads. If you don't have loads, then be a bit more restrictive, because of course the more TB LAMs you do, the more likely they are going to be negative. They're only positive in a very select group of patients. But the patients that they recommended on here is obviously they must be HIV positive, and it must be any patient who's admitted to hospital, irrespective of whether TB is suspected or not, and irrespective of the CD4 count, and irrespective if there's advanced HIV disease or not. So obviously you're also going to do your gene expert and your other investigations, but as an inpatient and you're very sick patient, you can have a very low threshold to do that TB LAM. You do not have to feel yourself restricted by the CD4 count. In an outpatient setting, we'll be a little bit more stricter. We assume these patients are a little bit better. A well patient, the TB LAM is hardly ever useful. That's why we're being sort of saving on resources. In the old days, we used to use a CD4 count of 100 as a threshold, but you can see how that's shifted now. And now irrespective, so the WHO still also recognizes 100, but here it is recommended in patients with signs and symptoms of TB and a CD4 count of under 200 or advanced HIV disease stage 4 or those who are seriously ill. So we have a slightly higher threshold also on our outpatients, but you wouldn't do a TB LAM on an HIV well patient who is visiting you as an outpatient. So CMSA, of course, is a negative TB LAM, because most of the times the LAMs come back negative. And we are going to take some bloods, and we're going to decide, we can review it if he's in the ward, we can review the bloods the next day. Maybe he was not quite so ill and we decided to bring him back as an outpatient. And depending on where he lives, you might bring him back within 3 or 7 days for those results. So how do we think about which bloods we would like to do? So yes, probably the first thing we think about is the full blood count, mainly to look at the hemoglobin. And a normocytic anemia is very helpful to tell us that this patient's been chronically ill for quite some time and makes us suspicious of TB in itself. It's not very specific for TB, and especially pancytopenias. The most common cause still of pancytopenias in our patients groups would be TB. CRP is useful, but not ESR quite so much, because ESR can be affected just by HIV in itself. The CRP is slightly more specific. If it's very high, great, high suspicion of TB. It's normal, it doesn't exclude TB. So again, you can't really use the one test on its own. We're going to have to use a combination of them. Liver function tests, definitely helpful, but let's not throw the whole panel out there. It gets expensive. So we're looking at a obstructive picture specifically. So your ALP, much more increased rather than your ALT. And this is typically because with extrapulmonary TB, there's often TB lymphadenopathy in the abdomen that might be pressing on the liver, or there's pieces of granuloma actually growing into the liver, and it therefore doesn't affect the hepatocellular function of the liver until very, very late. The ALT might be up a bit. The ALP and the gamma GT is much more useful as a potential marker for extrapulmonary TB. So those are some of our bloods that we can do. And as you can see, we'll talk a little bit about CUSP in a minute, because that's when we're looking further at our very sick patient. So other investigations that we'd like to do, if we can, is an ultrasound of the abdomen. And this we're very passionate about in looking at how to set up somehow through Zoom, if possible, to teach you guys out in district hospitals how to use your local little ultrasound machine that you wheel in from maternity and quickly check your patient for TB lymphadenopathy. So ideally, this should be able to be done in a district hospital setting. We already have hospitals with inspired doctors who are doing their own ultrasounds on patients. And that, for me, should become a skill that all district hospital doctors should have, but we're not quite there yet. And then if you can find a gland, remember a fine needle aspiration, always useful. Send two slides, two each, one fixed, one unfixed. And then the NHLS has got a very, if you get a proper bunch of fluid back, if it's quite a caseous gland, then you can send that obviously for gene expert. But you also get this little bottles from the NHLS. It's got some Bactec culture medium in it. And what you do is after you've done your FNA and you put your cells on your little slides, then you take the cells and you rinse your syringe in that culture medium, and you can send that for TB culture. So remember, your slides are not gonna is not going to be able to tell you whether those are live bacilli, and it's not going to be able to tell you whether there's MDR TB. So very useful to have that in the back pocket if you've got a gland you can put a needle into. And then of course, if you've got any suspicion of the CSF being affected, any suspicion of TBM, your lumbar puncture is a very useful way to help you get a diagnosis as well. A little bit worrying is that with TBM, 15% early on with TBM can still have a normal LP. So if your patient's got classic TB symptoms, classic TBM symptoms, you get TB in other places, but the LP is normal, that doesn't necessarily exclude TBM. And when you do your LP, you're obviously going to send gene expert on your LP, and even a trace. So if you get those trace gene experts coming back, very useful. You can even use that to confirm the TB on your patient. And never forget to send the TB culture also even on that CSF. So let's get back to our patient. So Mr. J, so this is now his blood results. So look at that, low HB, MCV 76.6, which is low, for those of you who don't remember your normal values. CRP of 35, it's always like 35. What can you do with 35? It's so useful if it's over 100, it's normal, but it's 35. And there's our liver function test. So we've just asked for an ALT, ALP, and gamma GT in this patient. So ALT is 76, a little bit up. ALP 234, about double what normal is. Gamma GT 302, about 6 times the upper limit of normal. It's very bad maths. But certainly much more of an obstructive cholestatic picture there. Unfortunately, none of you know how to do ultrasound at your district hospital, and there's no glands to put a needle into. So now we ask again, with this picture, at this point, would you start TB treatment if you had not yet started TB treatment? At the side, we're going to get our poll up again. If you're having problems filling in the poll, that might be your Zoom account, then you can put an answer on the chat, and we will pick up on the chat then, and then just put your name in next to it so that we can make sure that we know that you were on the call. So we will find you, don't worry. Great.
Madeleine, can they also put which poll number it is?
Okay, good. So this is
lots of polls.
So this is poll number 2. So if you do want to put the answer in the chat, you're also welcome to do that. If the poll doesn't come up on your Zoom, it has to do apparently with the Zoom version that you have. Great. We already have almost everybody have participated. Well done, guys. I'm going to share the results now. And we've got 71% of you will start TB treatment at this point, and 21.9% of you are still not sure and would like to have some more confirmation before we start. I'm going to also look at the chat, and we've got some yeses and we've got some no's on the chat there as well. Thank you, guys. Okay, let me just see how to close my poll so I can get back to my slides. Oh, the joys of Zoom. Okay. Sorry, I can't get to the button to close my poll. There we go. My poll is closed. So now I can get back to my slides. Great. So in the scenario, it's difficult because, in the scenario, we don't have anything yet that tell us that this patient has TB. He might have TB, but actually there's a whole lot of other things he might also have. And we don't yet have any bacteriological confirmation. The challenge is how long do we wait to decide whether our patient has TB before we start TB treatment? And this is the challenging balance that you have in the district hospital setting, because your patient is really sick and you need to start addressing what's happening sooner rather than later. So so the question is, at which stage do we cut our losses and say, okay, I don't have a bacteriological diagnosis, but I'm going to start anyway. So if you have a patient where you have a high suspicion of extrapulmonary TB, so you've got that hilar lymphadenopathy that we saw on x-rays, or you've got something that's making you very suspicious about intra-abdominal lymphadenopathy. So you've got that normocytic anemia, you've got an increased ALP and gamma GT, you've got an increased CRP, you've got an ultrasound bonus. But with this kind of a picture, and you've got clinical picture of TB, this age will be very difficult to say, I'm not going to start TB treatment. Any of your bacteriological samples is going to take weeks to come back. And even if that comes back negative, still does not tell you that your patient does not have TB. So in this kind of a scenario, you would have a very high suspicion to start TB treatment at this point. Any patient who's got a pericardial effusion with TB symptoms in a district hospital setting, you will start on TB treatment. You don't have to send them for an echo. You don't need to try and get a needle into that pericardium. Don't worry. TB pericarditis is very common in this kind of population. And if you've got anybody with a pleural or acidic effusion, TB symptoms, when you do a tap and you see and you look at it, oh, that's an exudate, when it starts clotting slightly, those patients we will usually assume has got TB, and you would start your TB treatment as well. So these are patients where your TB lambs were negative, your gene experts were negative, and you're wondering what to do. While you start TB treatment, you ideally still want to try and find at least 2, almost impossible, clinically relevant specimens that you can send for culture to have in your back pocket in case it ends up being an MDR, or in case it ends up not being TB, or in case it is just not responding to treatment and you want to know what's going on. So if you've got CSF, if you've got acidic fluid, if you've got pleural fluid, if you've got FNA, you always send for TB culture. One of the tips from Dr. Dave Stead, and this was before we did TB lambs, is to send a urine as well for TB culture, ideally an early morning specimen. And in disseminated TB, there might be yield there. And those are the kinds of patients that the TB lamb might be positive in. So if you've got a TB lamb that's positive, I would send those urines off, because at least then you've got a culture that you can test for sensitivity as well. So important to see if you can try and at least get a sample, and you will thank yourself later if your patient's not responding to treatment. So just a couple of caveats at this point. So we talked about admission earlier. If your patient is very ill when you are looking at them, so when you're coming in and you're looking for those CURB 65 signs, for example, any patient that's confused, tachypneic, hypotensive, and this is where your cusp becomes important, any signs of renal failure, any signs of DIC, any signs of ARDS. If you're suspecting septicemia, you need to take blood cultures at the same time, and you're obviously going to admit your patient on antibiotics while you're working them up for everything else. So important is to not just chase one diagnosis at a time, look at what your patient needs. The second caveat for your extrapulmonary TB is that you now don't have a nice, clear, confirmatory test that you've done at the beginning that tell me that my patient's got TB. The most lovely thing we always love is having a positive AFB, and then at 2 months you do the AFB again and now it's negative, and you go, look, my patient is converted. With these kinds of patients, you're not going to be able to follow up AFBs. You obviously can't use Gene Expert for monitoring your patients. And so you have to look at a few other things on how you monitor that my patient's responding on treatment. And within 2 weeks, you want to see a very, very clear response that the patient's getting better. So you want to see definite weight gain. TB iris might confuse that. You want to see at least resolution and clinical features, including fever and night sweats, to be getting better. You can look at your HB going up and your CRP coming down, and your patient generally should be reporting less fatigue and feeling better. So this is now before we've started that ARVs. We want to see, is my TB treatment working? Otherwise, you want to start looking for other things. So we decided to start Mr. J on TB treatment at this point because we were worried that we were never going to get an answer on his TB. And we also note that he's got a low MCV. So here's our next poll. Would you treat this patient for iron deficiency anemia? So just to remind you guys, and that'll be on, hold on. That was the, I need to find my right poll. Sorry, I'm still a newbie with polls. Oh, there's poll 3, excellent. Great. So yes, so our question now is, we've got now a 27-year-old suspected extrapulmonary TB, started on Rifampicin. HB is 7.5, MCV is 76. Would you give this patient iron supplementation? Haha, interesting question. So we've got lots of response here yet. I'm just going to... Stephanie, can I just ask you to mute all our participants? I have made you co-host, just because it might get interrupted. Great. Okay, and we've got lots of answers there, 85% participation, excellent. And you can put things on the lots of no's here on the poll, on the chat. So we have got a 73% of people said no, they will not give iron. And 27% of people said yes, they will give iron. There we go, excellent. So interesting. So why would we not give iron, and why would we give iron, and why is this a debate? Surely. And the debate has come in, especially in our clinics. So you will notice any patient in the clinic who is iron deficient gets iron, well, who's got a low MCV will get iron, or anybody with anemia for that matter will get iron. So why is this obviously an issue? And I think the reason why a lot of us were saying no is that because all growing cells love iron, including TB. And so I think most of us know that if there's no evidence of iron deficiency anemia, my poll's just popped up, excuse people, I'm just going to close it, there we go. If there's no signs of iron deficient anemia, then we do not give iron, because the iron is going to be growing your TB just as happily as it's going to be growing your own blood cells. So even if the patient's anemic, but it's anemia of chronic disease, we will not give iron. Where the debate has been is, what do we do with patients with a low MCV, or you might even have done an iron studies and you have found that the iron levels are actually low. And this is a nice little study from 2003 actually, where they were looking at what happens when we give iron, just in terms of the usefulness of using iron in patients with TB, with known iron deficiency anemia. And certainly if you do give iron in these patients, it leads to a quicker recovery of the hemoglobin early on in the disease. We don't know how bad it is for the TB or not. So there are some people that are saying, as long as there's definitely confirmed iron deficiency, we can give iron safely. But the actual impact on the anemia vanishes after 2 months. So in the control group, where they didn't give the patients iron, but they also had a confirmed iron deficiency anemia with TB. After 2 months on TB treatment, they recovered their hemoglobin themselves, and they recovered their iron themselves without needing supplementation. So this is just to, again, put the ball in your court, and you will make a decision on your patient on how concerned you are about that HB, what's happening with their nutrition. And generally, it's not necessary to put these patients on iron. And then generally, you want to think twice before deciding to give a patient with TB and anemia iron. So interesting. Great, so back to our lovely patient. So we've made this provisional empirical diagnosis of TB. Excellent, we start him on Rifampicin. Can we relax? No, we cannot relax, because the worry is our patient's got AIDS, and so there might be other things. So the next thing we want to look at is there any neurological symptoms that I also need to worry about? And if that CD4 is under 100, remember we need to just make sure we've got our CRAG result. We've had patients like that there's a CD4 count in a file, but nobody's gone to look at it properly, and they've got a positive CRAG, which everybody has missed. And remember, in the current guidelines, if the CRAG's positive, you have to do an LP. It's no longer symptom related. And if there's any neurological symptoms, and just mild confusion or headache, you must do an LP, send for, don't forget to do your gene expert and your TB culture on that. You can tap lots of fluid safely. I will send you some slides on that from Dr. Kabengele, who's put together some lovely summary on how much fluid you can safely tap. Short answer is a lot. And remember to do an opening pressure when you do your LP. So with cryptococcal meningitis especially, your patients can have quite a high opening pressure, especially if they're very sick. And that in itself can give you a clue to start the amphotericin B while you're even waiting for that LP result. And remember, even a trace gene expert result is significant on a CSF. So that will confirm that this patient has got TB of the brain. So in this patient, you want to have an high index of suspicion, because remember, if your patient has TBM, this is going to start to influence when you're going to start the ARVs, and it's going to possibly influence how long you're going to give the TB treatment for, depending on how severe that TBM is. So some patients you can manage with a 6-month course, but some patients we manage with 9 months. But especially for your start date with your ARVs, you want to know, do my patient also have TBM? And so a lumbar puncture was indicated in Mr. J, which was normal. So unfortunately, and we're still waiting for that TB culture, and who knows, maybe something will come back on that. So now we've checked on neurological symptom, and just remember, you're going to have a good look at the LFT. We've already spoken about the liver functions a little bit. Obstructive picture, you're thinking of things pressing on the liver, masses in the liver. Sometimes you might see a hepatocellular picture, then you want to look specifically for hepatitis B. Remember, it's spread in the same way as your HIV. And remember, our patient also complained of diarrhea. So for any patient who's had diarrhea for longer than 10 days, you need to send a stool MCNS. Now, MCNS is very unsatisfying in HIV negative patients and can be very satisfying in HIV positive patients if you just do it enough. And they can grow the weirdest and most wonderful things. Clostridium difficile, if people have been throwing antibiotics at him in the clinics. And remember to try and give at least 3 samples, especially if it's very watery diarrhea, or you might just miss the hocho. And if you've got a patient with chronic diarrhea and you've done all your stools, MCNSs, and nothing comes back, your patient's still pouring diarrhea and losing weight, now it becomes important to actually start referring and looking for other things. So you're never going to diagnose a Kaposi of the gut or a herpes of the gut or a CMV of the gut by doing a stool culture. You might end up needing a biopsy actually of that gut. So don't wait too long before you refer them in. You can also do blood TB cultures for MAC, and you can also try a blind course of Bactrim and metronidazole, but we don't generally like doing that. And this is mainly when you're busy starting to run out of options while you're waiting for investigations. You've got ascites with an exudate. We mentioned that earlier. You're going to assume TB. And remember, we're also going to do that cusp. So a lot of our patients either have an acute kidney injury because they diarrhea and they're not eating and they're malnutrition, then it's hot and they're just a bit run dry, and you give them a bit of Bactrim and fluids and they sorts it all out. And some of them might have chronic kidney disease because of high ban and will need its own separate workup. Great. So just a couple of quick top tips on watery diarrhea. So the 2 most common organisms that we're thinking about in the low CD4 count with watery diarrhea is either issosporiasis or cryptosporidiosis. Issosporiasis, by the proper name, is cystoissosporiasis, which is useful when you search it in the EMG. Now, I've mentioned earlier, try and get enough samples or you're going to miss it. So don't just send 1 MCNS. So if they're going home with bottles, you give them 3 bottles for 3 days with 3 forms, and you tell them every morning, please bring us back 3 samples, or you might just miss it. And your most important intervention is still art. So it doesn't matter what you do for this diarrhea. If you don't get the CD4 count up, it's never going to solve it. And for issosporiasis, we can also treat it with Bactrim, if allergic, with ciproflox. But cryptosporidiosis, we don't have treatment for. The only thing you can give is art to get that CD4 count up. And in these patients, actually, probably the only time I would ever use loperamide. I've got issues with Imodium and infective diarrheas, but in this scenario, that might be all you can do while you're waiting for that CD4 count to climb and for the patient's own immune system to sort out his crypto. So we get our stool MCNS back on our patient, and it confirms it's a spora belli. So we can now at least treat that. That's very satisfying. Patients think you're very brilliant. And we can add in Bactrim, 2 tablets twice a day for 10 days. And you want to make sure you add in some dietary supplements and some oral rehydration for this patient. Remember, he's losing massive amounts of weight. His TB and all these other diseases are busy sucking energy. And you want to give him some extra supplements there. Some of your district hospitals have got dietitians and might even have supplementation bonus. Some of you might not. My favorite advice to patients is to find out if they like mass, and one can also use milk or yogurt. So in 1 glass of mass, you already have 650 kilojoules, 8.5 grams of fat, some 12.5 grams of carbs, and 8 grams of protein. So if you had 3 cups of mass a day, that's already your 500 calories, which is normally what we try and get in over and above the normal diet. So you say to your patient, I want you to eat your normal diet, and please, instead of buying Twizzler, rather buy a Marcy. It's a food as well as a supplement. It will help for rehydration. It's easier for people who don't have much appetite and who can't eat big plates of food. So just the last couple of slides on other things you want to still think about. Cardiovascular, I've put lower down because it's not that common. But remember, TB pericarditis, common in, well, TB pericarditis is the most common place you'll see TB pericarditis is in our rural HIV populations. But TB pericarditis in itself is quite uncommon. And usually if you see a typical TB symptomatic picture and you get that beautiful globular heart on the X-ray, you can start them on TB treatment. ECGs can be helpful. Sometimes the X-ray is not helpful if it's constrictive, and you might actually need an echo. If your patient's very swollen, very short of breath, constitutional TB symptoms, with heart symptoms, you might need to refer them urgently up the ladder for better investigations. And just on the cardiovascular system, just don't forget about DVTs. And if they're short of breath, you need to think about pulmonary emboli as well. And then lastly, not because it's uncommon, it's actually very common, but probably won't be the first thing that kills them, is don't forget the skin and the mucosal membranes. We once had a patient admitted to Nkobela, also with TB. And then when we lifted his, examined him, lifted his trouser legs, he had big, thick nodular Kaposi sarcoma of both legs. And of course, he went in and was diagnosed with his TB, gene expert positive. And so everybody was treating the TB, and it missed the fact that he was actually having severe advanced end-stage Kaposi sarcoma. Always look in the mouth. You know, with the masks these days, one forgets to look in the mouth. Oral candidiasis is quite often part of the picture. And watch out for that Kaposi on the palate. So if you have internal Kaposi, even with no skin symptoms, a lot of them will have a lesion at the top of the palate. And yeah, look for those nodular or other suspicious skin lesions that might also need to be managed. So there is a point when you start running out of options of things you might be able to do in the district hospital. Remember, in your pancytopenias that are not responding to treatment, they might need a bone marrow biopsy, so you're going to refer them up the ladder. If you've got lymph nodes where you're not finding TB and you're starting to get worried about lymphoma, they might need a biopsy. Lung biopsies sometimes, like my patient with a mesothelioma, where we couldn't figure out why they weren't responding. I've mentioned the chronic diarrheas. Don't sit on them too long. They might very well need a sigmoidoscopy or colonoscopy and biopsy to find all those weird and wonderful viruses that might be causing colitis. And don't forget your blood cultures as a possibility for any patient with fever and advanced and severe disease. So there's a point as well. So this is already things where you'll be referring up the ladder. And a simple point of rule is, when do I decide that I'm going to call my regional hospital? Firstly, if you don't have a diagnosis. So sometimes you've done all the investigations you can and nothing is actually clear enough, or you need a CT scan to be able to see if there's a space occupying lesion and you can't do the investigation in your hospital. Don't be shy, fight for your patient, advocate to get those tests done. And the other important thing is if your patient's not responding to the treatment that you're giving, at least discuss. So you've got a classic pneumonia, you throw the whole book at them, you think you don't know if it's pneumonia or PCP or TB, you start them on treatment for everything, they're not responding to treatment. You might be dealing with an organism you're not going to be able to diagnose in your setting and send them up to a place where they can perhaps even do bronchoscopies and more advanced investigations. Just to keep in mind is what's going to kill your patient while you're busy waiting and investigating. Watch out for severe bacterial infections. So I mentioned earlier, the septic patients, take cultures, start antibiotics earlier. Make sure you don't miss those AKIs and manage them early. You don't want your patient to die from renal failure while you're busy figuring out what's going on. And patients like that can be put on peritoneal or hemodialysis while you're stabilizing them. And those serious OIs, your disseminated TBs, your cryptococcal meningitises, you've got to find them early, get them onto treatment early, treat on index of suspicion if you have to. Whew. Marathon through our workup of our very sick patient. At this point, if you've gone systematically, you hopefully have found the package of stuff that you need to manage your patient for. And now I'm going to just have a couple of slides, well, a few bit more than a couple, on what we're going to do with the ARVs in this patient, as this is an HIV talk after all. So just to remind us, this is our patient, right? 27-year-old, CD442. We've now diagnosed him with TB. And we go back on the NHLS and we go and find all his previous viral load results. Remember, he took some tablet, one tablet, so we assume TFE in 2018, 2019, and there's 3 viral load results. And his viral load in June 2018 was 6,432. We're not sure how long he was on ARVs for even. December 2018, 6 months later, a bit late, should have been 3 months. Viral load was 89, it's pretty good. And then August 2019, viral load 320, right, okay. So we've got no other results since then. We're going to do another poll. I like the polls. And which ARVs are we going to start at this point? Let me just launch my little poll. Oh, okay, there we go. Hold on, no, sorry, let me do that again. Dear, no, that did not work. Apologies. I went too quickly. Relaunch poll. Oh, good. Okay, apologies for that. I'm still getting to know. I've relaunched the poll. So we've got 4 options here for those of you that are on live streaming. We can either give TLD, we can either with the boosted, we can give tenofovir 3-TC efavirenz, we can give AZT 3-TC lopinavir ritonavir, and the lopinavir ritonavir obviously boosted, or we can give AZT 3-TC dolutegravir, the dolutegravir obviously boosted. Oh, lots of excitement. We're getting answers for all 4 options. That shows that this is not a straightforward question. We like those. Great. Okay, good. Excellent. Getting good. Good participation here. Very good. So, oh, there's still some more people. Okay, excellent. And we've got some in the chat if you can't see the polls. Great. And we've got 89% participation, which I think is pretty good. So I'm going to end the poll there and share the results. So great. So we have 61% of people will give TLD with boosted dolutegravir. 17% of people will give tenofovir 3-TC and efavirenz. 7% of people will give the old second line, AZT 3-TC and lopinavir ritonavir, and 15% of people will give the new second line, AZT 3-TC and dolutegravir. Oh, this is not a straightforward question. And there are probably different opinions on what you can do. And what I want to do is I want to show you on what kinds of things is making us, what feeds into this decision. So number 1, the management of treatment interrupters. So this is straight out of the NDOH guidelines, and it's a general recommendation on what you do on anybody who has interrupted their treatment. And the basic philosophy is simple. If at all possible, and you're not sure if their viral load was suppressed, or you don't have any viral load results, or you're not sure, basically, just restart the same regimen again. So in that case, we would just start whatever they've been on before, and then you do your viral load 3 months later while they're now on ART, and now you can decide, okay, this regimen is still working, we're going to keep this patient on this regimen, or no, this very regimen is not working, maybe we need to change this patient to second line. So it's not so much that you just say, I'm going to use the old regimen and they're just going to stay on that forever. You do a small test of their previous regimen to see that it's working. So that's factor number 1. It's not the only factor. Factor number 2 is the drugs that we have available and how they interact with TB treatment. So we have a couple of problems. There are some drugs that's just a pain in the ass to give with TB treatment. So nevirapine, just for the record, not good to give with TB treatment. We generally avoid that. Lopinavir ritonavir, as you know, you've got to double the dose of the lopinavir ritonavir. And that usually means going from those 2 massive tablets twice a day to 4 massive tablets twice a day. Not fun for those of you who have had to take Eluvia. And if you use dolutegravir, you also have to boost the dolutegravir. So dolutegravir also 50 milligrams BD. And we still don't have quite enough information exactly about the influence of rifampicin on dolutegravir. We're hoping that the boosting will be adequate. Just a caveat here, which is not on this slide, another drug you can't give with rifampicin at all is atazanavir ritonavir. In those cases, you have to change your rifampicin to rifabutin, little aside. But because of all of these interactions, the guidelines actually recommend that if you start somebody new on TB treatment who's never been on ARVs before, your first choice will actually be TFE, because it's a regimen that agrees very nicely with TB treatment. We've got lots of experience with TFE, efavirenz-based regimens and ART, so we quite like to give efavirenz if patients got TB. If the patient's already on TLD and they develop TB, then you'll keep them on TLD and you boost. But if you've got a choice and you can start from scratch, then efavirenz will be your first choice, just because it's easier, 1 tablet a day, and we know it agrees nicely with your TB treatment. Our third factor is our definition of biological failure. So the idea is that if we know the patient was biologically failing before they defaulted their ARVs, then we will start them on the second line. And in that case, it'll be the new second line. But if we don't know whether if the patient wasn't defaulting or wasn't failing, then we would try the same regimen again. So I'm just going to run quickly through the definitions of biological failure, because this is like bread and butter. This is the basics. This you've got to be able to recite in your sleep when I wake you up in the middle of the night. So if you've got a patient who is on the classic first-line regimen, abacavir, 3-TC efavirenz, or tenofovir, FTC efavirenz, then there's these 3 factors, right? You need a viral load that's over 1,000 twice after you've done your ABCD. I'll talk about ABCD in a second, over a 3-month period. So the idea is a patient comes in, the viral load is high. I check for factors that might increase the viral load. That's my ABCD, adherence, bugs, opportunistic infections. Are they on the correct dose? Are they on the drug interactions? You're going to go look this up in the guidelines tonight. And then you do your viral load again 3 months later. If the viral load is still over 1,000, we can assume the patient has failed if we've addressed all those factors, and we're going to change them to the new second line, which is AZT 3-TC dolutegravir. Okay. I'm just going to talk about the other definition here. If your patient's already on TLD, or your patient's on the old second line, AZT 3-TC lopinavir ritonavir, those drugs are tough drugs, they're tough regimens. So our definition of biological failure is different. Now my viral load's still over 1,000, 3 times, also checking my ABCD every single time. But look, they have to fail over 2 years before I start getting excited about genotypes or changing to second line. So there's a huge difference depending on what the patient has been taken before. So our patient, remember, was taking TFE. And this brings me to the 4th factor, which is about a low-level viremia. So low-level viremia causes a lot of confusion because we know that if our patients had a viral load that was LDL prior to defaulting, then we restart the same ARVs. If can you just mute somebody there for me? Thank you. Cute baby on the line. Thank you. If the patient had a viral load more than 1,000 prior to defaulting, remember that rules of more than 1,000 3 times apart, or you slip, no, he was not doing well, then you can change to second line, AZT 3-TC dolutegravir, no problem. What do we do with a low-level viremia? And what do I mean with a low-level viremia? So low-level viremia is when you have an occurrence of at least 2 viral loads of between 50 and 999 during while they are on ARVs. So if they're under 50, it's fine. If they're over 1,000, we know what to do, but you have this gray area in the beginning. We talk about viral blips. So that's somebody who was LDL, and then the viral load is between 50 and 1,000, and then it's LDL again. That we just call a viral blip and can be caused by a variety of odd little factors. But persistent low-level viremia is that if you've got at least 2 in a row where it stays between 50 and 1,000. So most first episodes of a low-level viremia like that are just viral blips, most of them, and they'll just go away again. So we don't stress about them. And then a minority of them will then become this. Every time you take it, it's never LDL. It's always somewhere between 50 and 1,000. And certainly studies show this, and I've certainly seen this in our ARV clinic at CMH, is that it tends to be your patients on PIs. Every 6 months you do the viral load and it's like 70, and now it's 200, and now it's 180. And the idea about it is that these patients have a higher HIV reservoir. Maybe they've got more history of more advanced disease. And they usually have a history of having either defaulted treatment or not taking treatment well. And you get some patients who are fully adherent to their meds, and they still have a low level of viremia. And you get those who are, missing the odd tablets. They take the tablets very well the week before they come for their viral load. And they might have these little coats. And generally, although we do our ABCD, we don't want to start changing regimens and throwing more drugs on them for low-level viremia. Although there's a higher risk that this is going to become viral load resistance, we tend to hang 10 and watch them. And so the general approach is we approach it a little bit like we do our normal criteria, and especially because it's mostly on PIs. So I would normally watch a low-level viremia over 2 years. If over 2 years, my viral load keeps on being between 50 and 1,000, so it's not over 1,000, I would discuss a patient like that before I would genotype. The challenge with genotyping a patient with a low-level viremia is if the viral load is very low, especially under 200, there's a good chance your genotype's not even going to work because there's not enough virus there to actually do a genotype on. And there's a question that even if there is a little bit of low-level resistance going on, do you really want to start throwing new drugs at them if the drugs are predominantly suppressing the viral load? So it's not a nice clear-cut area, but it's not an area we would yet address aggressively. So in our patients, when we saw our patients after 2 weeks on ARVs, because of all these factors, he'd been on ARVs, he'd been on TFE in the past, so we're restarting the same regimen. It's a nice regimen to give with TB treatment. Although he's got a low-level viremia, we're not going to stress about it too much because his viral load was not over 1,000 the last time he's defaulted. And so I think it's safe to do a test of tenofovir, FTC, and efavirenz on this patient and avoid all the boosted regimens we're going to give him. We're obviously going to watch him very closely. So within 3 months, we can repeat that viral load to make sure at this stage, is this regimen working and do I need to change him to second line? If your patient's very sick and you're really worried and you want to decide quite quickly, is my regimen working or not, you can make that interval quicker. But then you're going to need a baseline viral load. And then you can do a viral load after, say, 1 month and make a decision. And for that, you need logs, which is, I think, my last slide. So quite sometimes you will do a little test to figure out, is my ARVs working? And the simple rule is a very effective ARV regimen will lower your viral load by at least 1 log a month. So to do that, you've got to know the logarithmic scale. I don't know if your maths are like mine. If you have a calculator, it's best. Take the 2 viral load, do it on the calculator. Don't do it in your head. When you're tired, you're going to get up with the wrong results. And if it's less than a log, it means your regimen's not working. So I'm just giving an example here who's got a patient who's got a viral load of 156,000 before we started him on his ARVs. So let's say Mr. J, this was his viral load before we restart the ARVs. Then at 1 month, we expect that viral load to be under 15,000. You can see it's dropped by 10-fold. You just wipe off the last number. After 2 months, it will be under at least 1,560. Again, we wipe off the last number. And after 3 months, we expect it to be under 156. Now, this was still in the old days. This numbers we used to have when we used to roll our D4T regimens. Dolutegravir, for example, and some of our new regimens are even much more powerful than this, which is why we expect the vast majority of our patients at 3 months, that viral load is going to be LDL or at least under 1,000. But if you've got less time to make the decision, you can use your logs to decide, are my ARVs working? So we're going to complete our dear Mr. J there, who's now on ARV. Sorry, Steph, you just muted me as well, but I've unmuted myself. Thank you. So we've got Mr. J now. He's on TB treatment. He's on Bactrim. He's on treatment for his Isospora. We would have managed his oral candidiasis and anything else that we've picked up, and we would have put him on some supplements. So in summary, what we want to be able to do when we work up our patients is you start off looking for TB and respiratory infections. You're going to look for extrapulmonary TB if you don't find anything, or even if you find something on your first test. You're going to make sure your kidneys are okay and your patient's not septic. You're going to check your neurological symptoms, look at your abdominal signs, and then finally check your skin and mucous membranes properly. Don't forget your other STIs. I'd like to now open it for questions, and I'm going to put up the poll just in terms of some feedback. And polls, let me see if I can